Hey, Dr. Hicks. This is our patient Jennifer again. We are almost there. You and I had spoke yesterday about solving the issue of um, trying to close that space in the anterior. So on the right side is her original, so that's where she is right now. Say original as of right now. Because she's in coupling of the anterior teeth, in other words, the front teeth are touching, we cannot close that space unless we create some space somewhere. The most common solution here is to do IPR on the lower, which I don't think is a bad idea, but as you and I agree, retractive orthodontics is something we try to stay away from. Unless there is a need to decrease some embrasures, I will say that she has some there, so from a hygienic perspective, that is something we could possibly do. But we had agreed on trying to solve this without any retraction. So the first thing I'll typically do when we have a case that starts off like this is there a Bolton discrepancy? In other words, is the problem a tooth size problem? And as we can see here with the Bolton analysis, we only have about 1/10 of a millimeter size discrepancy with this patient. And what that means is she's more likely having an issue with space problems here because of a sagittal skeletal relationship. And as we can see, she's a little bit class 3 here with the molars. If we look at the other side, a little bit less so. What do we typically see when there's a difference in the sagittal relationship? From left to right, we tend to see a midline discrepancy. As we know, solving midline discrepancies is something that should be avoided as an absolute treatment objective, because people do not notice midline discrepancies until you get to about 4 to 5 millimeters. If it's a patient treatment objective, our first goal is to educate them that people don't notice it. And if they want to solve it, then we just let them know what it's going to take to do that. This patient here, I believe, did not necessarily have that treatment objective. And why do I bring this up? Well, fixing midlines is something that is hard to do, involves a lot of elastic wear, patient compliance, and time, all things that might be a little bit overkill considering the fact that nobody actually notices these. We as dentists tend to make this an issue more than the patient does. But not uncommon to have a patient say, hey, I want to fix this. So we should be armed with the know-how how to do it. Well, if it's a sagittal issue from a skeletal perspective, and we're going to try to solve this with a dental solution, what you and I had come up with is to increase the overjet as a way to create space to close the diastema between the front teeth. It looks like they programmed quite a bit of the space on the distal of the canine. I had seen in your description here that you had said spacing distal to the upper laterals in canines is acceptable. I would just be specific on how much of that space you want distal to the lateral. I think the lateral is a little bit small here. I did a space analysis earlier using the golden proportion. I won't bore you with the details here, but let's just take a look at the analysis tool I use. I have this little worksheet here, and I'll do a separate video for it, but you have about 0.5 millimeters that you can add to the laterals on either the mesial or the distal in order to keep the golden proportion where it needs to be. The golden proportion is not an absolute tool, it's a relative tool. It's just something that helps us go in the right direction. I think here, if you add 0.5 millimeters to the distal of the lateral, I would have them decrease this overjet by 2 millimeters. 4 millimeters sounded good when we talked yesterday, but that's a little too much. And I don't think we're going to achieve that in 9 trays. That's quite a movement and likely to cause some fenestration or recession of the upper anteriors where that bone is very thin already. So I would program 2 millimeters of overjet, have there be 0.5 millimeters split around the lateral, I would have them close this space and then leave the resulting room here on the distal of number 6. And if you can rewind that and go in that order, what that might do is it'll correct the midline discrepancy potentially. If we can do it, why not? And I think this is a good opportunity for us to do so. It will increase the spaces around the laterals to maintain a slightly more aesthetic perspective. It will decrease the overjet to a more favorable outcome without causing some periodontal compromise. And it'll help close this space. Lastly, I would ask for them to always have the number of trays equal out. If you're going to have the patient wear trays, you might as well have them be active trays. What can you do on the bottom while the upper trays are being done? Typically, intruding the lower 3 to 3 is a good idea for a patient with a deep bite. She doesn't necessarily have a deep bite, so I don't think we need to do anything there. Yeah, I would just say have the number of trays be equal, and I bet you'll have a nice perfect outcome here on the lower. Alrighty, hope that helps.